Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have our presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the Q&A pod located to the left of your webinar platform. You may also download a copy of today's presentation using the Resources pod located below the Q&A pod. It is now my pleasure to introduce today's first presenter, AHA moderator, Monique Showalter. Please go ahead.
Thank you so much, Stephanie, and welcome everyone today to our first webinar, and we are delighted to be hosting so many of you. All of us here at AHA hope you are safe and well, and thank you all for your organization's service and dedication to the patients of your communities. AHA is pleased to be hosting today's webinar entitled Innovation and Practicality Drive the Future of Virtual Care, featuring the Froedtert and the Medical College of Wisconsin Health Network sharing their best practices of its evolving virtual care experience. This webinar is brought to you through the generous support of Accenture. Today, we'll hear how the Froedtert and the Medical College of Wisconsin Health Network, like many health systems, hospitals, and provider organizations, relied on virtual care to respond to COVID-19. In this webinar, we'll hear details of Froedtert and MCW Health Network's experience, as well as Accenture's observations from several other health systems, providing insights on how hospitals can successfully transform use of virtual care to provide better care more effectively. Today's discussion will include how using virtual care has brought together patients, families, specialists, health professionals, and other professionals, including translators, into a dynamic, coordinated virtual experience versus the traditional one-on-one virtual visit. We'll also hear how patients facing complex conditions will use extended virtual visits, significantly exceeding the typical 10-minute urgent care visit. Virtual care will use timely workflow and patient data to enrich the support patients and families receive during a virtual visit. We'll also hear how scalable enterprise technologies expand virtual care options while also capturing real-time data to support analysis of interactions while also providing payment documentation. Note, too, that we've allowed time for your questions. We've already received several questions, which our speakers will address as time allows. Note, too, that if you wish to download the presentation at any point, you can easily do so through the resource section of your screen. Today's event is being recorded, and the replay link will be sent to all registrants and attendees shortly after today's event. So let me briefly introduce today's outstanding speakers. I'm thrilled to introduce one of three outstanding presenters for today's event. Mike Andres is the Chief Digital Officer for Froedtert Health and President of Inception Health, a company formed by the Froedtert and the Medical College of Wisconsin Health Network to accelerate the adoption of digital health, identify and partner with innovative companies, and increase the innovation capacity of the network. In his roles, Mike leads teams that provide 24/7 remote monitoring and intervention, software engineering for the enterprise's digital engagement platform, digital transformation project management, and corporate venture investing in digital technology companies. Mike's certainly busy. Mike is a fellow of the American College of Healthcare Execs and received a Bachelor of Science in Physical Therapy from the University of Connecticut, as well as a master's degree in business administration from the University of Arizona. Thanks so much, Mike, for participating in today's discussion and sharing your success with our listeners. We're also being joined by Mr. Greg Smith of Accenture. Greg has more than 25 years creating value across provider, payer, and life science companies. He currently leads the telemedicine and virtual health offering for Accenture's health practice. Greg has worked and supported telemedicine programs internationally, including within Saudi Arabia, as well as throughout the U.S. Previously, Greg led the Accountable Care Organization program at Dignity Health, and has provided telemedicine direction to a variety of providers, payers, and life science companies, as well as to the Veterans Administration, state hospital associations, and departments of health. Last but certainly not least is Dr. Darrell Gibbons. Darrell is a senior manager in Accenture's health strategy practice. A physician by background, Darrell has extensive experience in growth strategy, transformation, consumerism, and innovation in the healthcare industry. Darrell was most recently clinical director at Babylon Health, a telemedicine primary care provider leveraging artificial intelligence, and previous professional experience includes practicing physician in the NHS in England. Welcome, Mike, and thank you so much for your participation, Mike, Greg, and Darrell. It's now my pleasure to turn the floor over to Greg Smith to begin today's presentation. Greg, the podium is yours.
Thank you very much, Monique. And first of all, before we get into what we're going to talk about, Monique, thank you very much and the American Hospital Association for giving us this opportunity. The key to today is to hear less from Greg and more from Mike and Darrell. And so let me talk to you a little bit about what we're trying to accomplish today. Froedtert is one of the more interesting environments in which they have made a commitment to virtual care several years ago, which made it possible for them to address the unique demands and needs of COVID much more easily than we've found for other health systems around the country. And so part of today's conversation is to really, first of all, hear from Froedtert and hear from Mike about that experience, but at the same time to sort of set up a panel discussion between Mike and their experiences and Darrell, who sort of represents the experiences that we've seen from others, and sort of walk through the journey of where is virtual care, how did it respond to COVID, what did we find that was successful and measurable, and what were the outcomes that were very clear, and then sort of talk about where we see people going next, where Froedtert's going next, and where others are going. You know, what are their scalable technologies? What are they doing to scale? What role does innovation and what their journey is to get there? And so in a minute, I'm going to turn it over to Mike, and so that Mike has a chance to sort of give us background about Froedtert and all of the work they've done over the last several years. But I want you to draw a line underneath that top bullet on the right-hand side. That's where we want to open it up for discussions and questions. It'll be a more panel discussion, so there will be many opportunities for you to ask your questions, contribute to the discussion. We've received several questions from people in the audience, and folks in the audience, I know several of you. Thank you very much for attending. It's good to see you again. Please contribute your questions as we go through, and we will work to not only answer those questions that have already been provided, but we'll try to answer all of the questions as we go along. So I think as we do this, if you'll think more panel discussion, more back and forth, I think we'll get a lot more out of it. So the first thing I'm going to do, though, is that I am going to turn it over to Mike and have him give us some background and details about Froedtert and how they've uniquely sort of made use of virtual care and how they were able to respond to COVID. So, Mike?
Hey, thanks, Greg. It's great to be with you all today. I want to kind of first and foremost say, we're going to hear an N of one experience here. Hopefully it's helpful in some cases. We definitely are not suggesting that we are the holders of all answers. So maybe you'll see some things that we've done that you could even give us some tips on how to improve. But this sort of first slide that you see here, I think it's an interesting sort of example of where we're going to make a point to maybe deviate from what maybe the common interpretation of virtual care is. You see this image, and this is the image you see on, I think, websites, reports, other things. It tends to show basically a video conferencing, between a patient and a provider. And if there's anything that I kind of would hope that people take away from our perspective on this is that this is just kind of the tip of the iceberg when it comes to how virtual can actually change how care is delivered. So kind of keep that in the back of your mind as we go through this. If you don't have much, I'd say, sort of knowledge of Froedtert, I thought I'd at least also sort of ground you in who we are. We're a kind of middle-sized organization. We're definitely not as big as some of the, maybe bigger brand names nationally, but we've, based on our size and our sort of vision, we've taken some steps that I think have been somewhat unique in the industry. We are based in Wisconsin. Wisconsin is a pretty competitive state. It has some pretty high performing organizations in it. We are academic at our core. We have what we'd argue is somewhat of a more vertically integrated academic health system than maybe others, where we have a health plan, a third-party administration company that we own, and a lot of actually ancillary businesses that we own that are subsidiaries, even extending into the post-acute space. The one separate LLC that we own called Inception Health that may be most relevant for this discussion was founded about 6 years ago, and it really was our attempt to start to try to drive digital transformation through the organization through this separate but connected organization. And some of the work you'll see that we've accomplished really did kind of come from that initial investment. So that's sort of Froedtert, sort of in a nutshell. Where I want to start with virtual is credit to our partners at Children's Wisconsin. And really, I think this is the best way I've seen to describe what this paradigm shift is that we're going through, which is really enabled by virtual. So what you see on the screen is 365 days. So 365 dots here maybe represents one individual patient or community member that you serve. And in a typical world, this, our organizations, especially if it's a healthy person, might have extremely limited understanding of what that individual is up against for their health. You might see them once, maybe a year for some sort of episodic care, and then maybe once for a pre-planned annual checkup. In reality, that person has a whole bunch of other life events going on related to their health. And in a virtual world, these are all opportunities for engagement. So this is a simple example of a healthy 35-year-old. If we were to start to look at maybe one of the more common people who intersect with our organization, say a 65-year-old with type 2 diabetes, this gets more interesting because in a typical environment, we might see that person 4 times a year and maybe have a few ancillary visits that we can have an intersection with that individual. But this person, also has, day-to-day needs and day-to-day health-related either questions that they might go to Google for, attempts to try to, change their health based on behaviors, maybe actual data that's suggesting that they're not doing well from, a diabetes perspective. And the question we wanted to kind of pose, and I think, where we tried to take this virtual care technology a few years ago was, how would that change if we did really want to engage with somebody 365 days out of the year and empower it with virtual? So that's, that same exact 65-year-old in the future, we might see something that's looks a little bit more like this, where you have somebody who's responsible for care coordination, engaging with this individual throughout the year. Maybe some of those visits turn into asynchronous e-visits or maybe a video visit. If the person is having some of their own questions, maybe they go to a virtual triage self-service tool. And if we do identify some, patterns of maybe poor health or poor data, then maybe we put them on a remote monitoring platform and we start to prescribe a digital therapeutic to help them self-manage their condition. And it just creates this much more integrated experience for this individual that really in this, you see that the visits are actually the same, but the touch points could be 150 or 200 a year. So it really changes this sort of perspective. So how we've tried to bucket this work in virtual is in these 5 categories. First and foremost is in patient self-service. We think this is the one that's going to scale the most in the future and have, it really from an economic perspective is going to allow us to have a sustainable model. Clearly, we're still going to be doing visits, so there's still a place for visits. But then if you look what's kind of wrapped around those or in place of those, you have digital therapies, which we would argue are becoming better and better every day, and remote monitoring, sort of as somewhat of an overlap with digital therapies, but can be distinct. And then finally, care coordination for select groups of patients that we serve that is, it's always been virtual. So these are our 5 categories. And what I was going to kind of share was just what did we experience, over the last, year, especially with COVID, for each of these, and just sort of kind of tell a little bit of a story of some of the, either data that we saw or some of the key questions we had to address in launching these. So we start with patient self-service. This is, again, is the one we think is the most potential to scale. We definitely found that our community would engage with virtual triage. They, especially with COVID, we had just a whole lot of self-service, self-triage episodes that led people to, here's the next step for you. And with COVID, a fair amount of COVID, it was, do I need a test? And how do I get a test? And our system was positioned well because our lab had the capacity to do, I think, nearly a quarter of all the tests in Wisconsin by itself. So a quite, meaningful asset that's not virtual, but getting people access to it, we really turned to these asynchronous e-visits to get people to determine if they're qualified for a test and then get a ticket for a test and then get booked into a slot. And just 37,000 people from September through December went through that process. So not even a full year. We had quite a lot of uptake. And the thing that I also don't want to minimize here, because this has also been going on, whether it was through the telephone before EMRs or now through portal messages, there's a whole lot of care that takes place that's outside of the visit already that is virtual. Whether it was, again, call your doctor's office or now, send a portal message. Our portal messages are on track to be almost on parity with the number of visits that we do in person. So this is a lot of work for the care teams to manage that is virtual already. And so when you look at this, this space of patient self-service, arguably, to scale these things, you have to think of, are you going to have a centralized team to do this or a decentralized approach to this? And for us, for this particular body of work, we would, we're pushing towards centralization as much as we can, just to try to take some of the, day-to-day challenges off of our front lines sort of backs. And we know some of this will still remain decentralized, especially some of the portal messages will probably have to still be managed by the local care teams. But by and large, we want to try to centralize this work. So if we move from patient self-service, we go to the topic that I think everybody, when they saw what happened with COVID, these are the types of statistics that they like to cite. We did X number of hundreds of thousands of video visits, or we saw X percent of our visits, convert to virtual. And I don't want to minimize this in terms of its importance. It was still the ability to deliver care, where otherwise it may not have been safe to deliver care. So it's still important. But I would keep encouraging everyone to not think of visits as the be-all, end-all for virtual care. The way we approached it was basically just scaling up what we had already built pre-COVID. We did extend it to almost every care team member that would have one-on-one patient interaction. So that went into PT, OT, pharmacy, and beyond. So we didn't look at this as just sort of a pure physician or APP tool, but really a broad care delivery modality. For these, almost all of these, we would argue, are decentralized. This is about you visiting with your fill-in-the-blank provider, with the exception of our on-demand video visits. So these we stood up essentially right at the beginning of COVID, our own internal model to allow people to get assessed for COVID and a test ordered if they needed it. And we use that as a much more centralized pool to try to manage that volume, and it took off. I think we went from a few hundred of these a month to thousands and thousands a month, because it was a centralized, easy to access service that was basically on demand. The interesting statistics, when we look back on 2020, is that even though we're an academic medical center and very sort of heavily skewed towards specialty care, we still, over the entire year, saw about 20% of all of our visits were virtual. And that included even, the months that were pre-pandemic. Obviously our peak was somewhere around 75 or 80% of all visits were virtual during that very peak time. And like most in the rest of the country, we've seen that erode over the rest of the year. The other, I think, important statistic that we've learned, because as we've done some of our analysis, is that many new people came to our system because we actually had a virtual option that they could come through. So 25% of all of the new patients that hit our health system in 2020 came through a virtual channel. So it's definitely something that I think it's not a nice to have, it's sort of a requirement now. If we move into digital therapeutics, this is an area that Froedtert and the Medical College has been very bullish about over the last 5 to 6 years. I think we've been somewhat, at the forefront of kind of coining the term a digital therapy formulary and have built a formulary for our system. So we can now prescribe digital care for more than 35 conditions. You can see most of them up here, and they range from chronic disease tools to episodic care pathway tools. But in many of these cases, the attempt here is to try to give people a platform or a way to manage their condition through education and whatever the behavioral cues are that are built into these tools on their own, and only escalate to our care team when there's really something that's being flagged as something that needs intervention. These are the tools that we use that really connect with every one of those dots on that 365 dot map. And for us, for scale purposes, we've centralized most of these. So the care team that manages the back end of most of these prescribed digital therapies is a centralized team in most cases, because that is really the only way that we can see scaling it to the degree that we have. And in 2020, we saw quite a significant uptick. We do invite people to participate in these tools at a rate that's higher than 25,000, but we did actually have 25,000 people sign up and go through these care plans and engage with these tools, which for us was definitely a record year. Slightly related but different is remote monitoring. And while some digital therapies do have a remote monitoring component to them, we also look at this as a separate way to really engage. It's typically episodic. The big, sort of uptick we saw in this was COVID. And the kind of cool story we had at Froedtert was from very, very early days. So this would be in early March. If you were to have a COVID test with Froedtert and have a positive result, we created a care package for you. We called it a COVID care kit. And in it, it had a pulse oximeter, instructions to get engaged with our digital remote monitoring, a phone number to our 24/7 virtual care team. So if you ever had any problems, you could call 24/7, and a number of other sort of educational pieces of material to help you manage yourself at home. We eventually migrated that to, we just shipped you that kit the moment you had a positive test. So we were able to, for everybody that was positive, get them a kit usually in about 48 hours from that positive result. And then they could be enrolled immediately in remote monitoring. And over the course of 2020, this program's still ongoing, so these numbers are still climbing, unfortunately. But we did manage 10,800 patients in their home through this combination of pulse oximetry, this digital engagement tool that we used, and access for these community members to our nurses and our virtual care team 24/7. And it's just some amazing stories that kind of came through that. It was a scary time, and for people to have this lifeline essentially to our teams 24/7, I think really went a long way. Remote monitoring, though, is for us is something that is everything from the ICU all the way into the home, and so we leverage this centralized virtual care team to monitor all those environments. So instead of asking different clinical areas or different parts of the organization to monitor sort of specific parts of the care continuum, we've just centralized it all. We don't view this as something that people get, plugged into for life, but something that's more episodic in nature. So it might be until you get something under control or until you meet some sort of milestones, and then that remote monitoring is diminished. But this is obviously a space that we see a lot more applicability in the coming years as things move more into the home. And then the final virtual, kind of care bucket that we would say is distinct is this concept of care coordination, which I think almost every health system has. I don't know if they always think about it as virtual care, but this group, looking at people more holistically, looking at them across the entire year or beyond, has also used a lot of technology in our organization. Historically we've used telephone, but now we've got a variety of automation tools that they can use to engage with patients and basically scale their impact. And this group is something that we think also really needs to be centralized. To try to do care coordination in different operational units of our organization was sort of untenable. So we have centralized this, and it's been pretty effective. So that was sort of the end of what I wanted to kind of share just from our kind of story perspective. So I'll pause here and see if Darrell wants to pick up.
So Darrell, do you have any thoughts about just in general what Mike's talked about, and especially any areas that you want to highlight? I'm thinking, so Darrell used to work for Babylon Health, in which an awful lot of activity is in that first use case, I think, Mike, that you talked about. One of the questions, Darrell, from the audience talks about artificial intelligence and machine learning. So I think, Mike and Darrell, I'm interested in your thoughts as to whether that's clearly an area, or whether there are other areas in the spaces that you just talked about, Mike, that AI and machine learning can play. But Darrell, any thoughts?
Yeah, sure. First of all, just want to say what a remarkable journey that Froedtert had. Very, very impressive. Not everyone's been at that kind of starting point, so really great to hear something that's evolved in that way. I think related to the AI ML question, we have seen that being deployed, during COVID, partly on the kind of self-care piece that Mike was alluding to, right? So obviously COVID symptom checkers, which were some driven by AI and ML in that kind of sense, to help really expand the capacity, given all of the systems were so kind of overwhelmed with those potentially coming in with COVID. So a way of identifying those who essentially were at risk of having COVID, giving them some information as to what they should do, in order to be able to help de-stress some of the systems and allow them to keep functioning in that kind of overwhelming time. But Mike, happy to hear any other experience you've seen on the AI front during this time.
Yeah, I mean, you definitely hit exactly on how we started. We think about it as like, what process do we want to automate? That's kind of our starting point. And the triage front end space was where we thought that could provide a lot of benefits. So the tool that we use is, I think on the spectrum of AI, I think when you start to get under the hood and what, where you draw the line of what is AI versus not, I think that's an academic discussion maybe for another time. But we I think of it as, in many of these cases, like, is there something that we want to automate, and is there a good sort of tool out there to help us automate it? And so self-service and triaging is a great place to start.
Absolutely. And just building on that, I think one of the elements that we've seen in the market is ensuring that there's enough trust in the AI, and that's either from a patient or provider perspective, that it effectively enables that self-triage and relieves the capacity. Because essentially what you don't want happening is someone to go through, an AI-driven chatbot interaction, for example, but then still not believing the advice enough and then following through to interact with a person anyway, right? So you get that double interaction. And I think over time, we're getting to a space where consumers are more kind of comfortable there. I guess looking at the discussion and questions here, I know Mike's already given us, I think, all of the answers to this piece around the virtual care and meeting the challenge from that perspective. So maybe I'll shed some light around what else we've seen, more broadly across the market. And I'd say it's quite safe to say that no system was entirely prepared for the magnitude of COVID-19 and the sheer strain it put on capacity, finances, and the way that care was delivered. But what we saw is that this strain that was put on the system really did spur innovation across it. So we had a situation where there was a large displacement of care need and services outside of the traditional in-person channel, be it through safety and or capacity issues. And most, if not all, providers recognized that virtual care could help accommodate that displacement. That said, providers were truly at different starting points on their virtual care journey, as you've kind of heard from Froedtert there, when all this occurred. So the degree to which virtual care could successfully address the COVID-19 driven issues varied in a similar way. For example, if we take that capacity issue, creating virtual care capacity across the system to meet the call for providing safe access to care happened really rapidly, and from that standpoint was really quite successful. But when you look back into the deployment of that capacity, there was certainly variation given the pace of rollout and respective starting points of each of the health systems. We observed a huge spectrum from those who had never had any virtual care capacity and were essentially building it from scratch, to those who had so much virtual care capacity they'd been selectively providing it to other systems for a number of years. So specifically, I think we could touch on three main differences we observed in those groups. Firstly, in understanding which use cases were most amenable to virtual visits to ensure that capacity is used appropriately and efficiently. So some systems had really mapped out across patient to provider and provider interaction, as well as applications beyond ambulatory to include acute and post-acute settings, what would work or wouldn't. And we've observed over 100 different use cases being deployed. And some of the broad themes that we've observed in those systems that they've actioned include a functionally led view. So that's where you've got clinical activities which can be performed at a distance, such as ongoing management of chronic diseases, pre and post procedure assessments, etc. I'd say a service line led view, so diseases where there's limited need for tactility, where you don't really need to touch the patient, such as behavioral health. And I think, and thirdly, a workforce management led view, such as services where a shortage supply could benefit from a one-to-many leverage model, for example, intensivists spread over multiple ICUs in an EICU model. I think a second difference we've seen in the market is in operationalizing the capacity, so that there is minimal disruption to both patients and providers, such as the degree to which the technology and the workflow integration actually occurred, or having virtual care specific protocols and procedures which were sensitive to both the different care settings and the care team members, or developing training programs to help establish parity to the in-person experience, and for some systems to actually try and establish superiority in some respects. Or perhaps the coordination of responsive tech support on both the patient and clinician front. Or to round this out, virtual visit demand forecasting models and the configuration of that supporting virtual workforce, which could be scaled up and scaled down as needed. I think the third and final difference to touch on here before I kind of put the mic down would be on the financial sustainability of the capacity. So not just the integration of the existing care model, but redesign of the care model with virtual care as part of a broader consumer-driven approach in a way which is financially self-sustaining. And we've seen some of this happen with the most advanced systems that we've seen in the market. Maybe back to you here, Greg.
Yeah, so I think those are great. And Mike, I'm curious, in your journey over the last 5 or so years, and not just in COVID, what has been the role of the clinicians within the organization, and how have you managed both their input, the change, how to redesign the care model, those kinds of things? How did you get that success in those relationships?
I mean, it's a great question. I think each of these are just modalities, and so the answer was, we had to work with each of the service lines, or I'll say like product lines of the organization, to determine what, essentially they thought they were going to be competing against and how their model had to change. And what of that sort of menu of different virtual or digital tools that we had available to them would fit best. And I think when they were involved, with that selection process or that sort of discernment, there was a fair amount, of adoption, because they had a, some say in how that would work. And you can imagine it's very different from an orthopedic surgeon of like where they see their practice going and what the role of digital is versus a primary care physician and who they compete against and all those other things. So it's a nuanced discussion because there is no one size fits all for it, but that's how we approached it. It's sort of a little bit of an outside in approach where we said, all right, what do you have to do to be competitive? Showing essentially what some of those new emerging competitors are trying to do, which in some cases are virtual, they're virtual by design. And then helping them to come up with a good plan to evolve their practice.
Right. So, and I'm assuming because of all of that work, and I hear it in your voice that says that's why it was possible for you guys to be able to respond to COVID in a much more proficient way than what we saw in many others, and you didn't have to scramble for a bunch of new technologies like we saw in many places. Susan has asked an interesting question. So, who's responsible for preparing the workforce to do virtual care at Froedtert?
Yeah, it's a team effort. So we do have the physician leadership. They do lead from a sponsorship standpoint. We have typical training resources that may have been, say, devoted towards EMR training that can also be deployed for at the elbow support. And then we have, a broader organizational development department, which is helping with some of the change management aspect of this. So there is no sort of one single individual that's responsible for this change, because it's one thing to know the technology. It's another thing to actually say, I want to use it. And I think if organizations don't address the broader, why would I want to use this question, all the training in the world of how to use it is kind of pointless.
Right. I think I've been at this now 30 some years. About 5 years ago, we had an opportunity to work with which is clearly, much like Froedtert, one of the premier organizations doing virtual care. And they were internally serving prior to us sitting down and having conversations, and they were looking to go commercial. I think one of the most eye-opening experiences in that discussion was the significant recognition and need for change management and how that, yes, you have clinical, yes, you have technical, but if you don't bring in sort of that change management expertise and capability and surround that whole team with this attempt to get people ready for virtual care, that you will find places then in which it doesn't work as well. Susan has also asked another question, and I'm going to push it to the end, Susan, which is the reimbursement question. So we're going to get to it, and we're going to come back to it. But Mike, I do want to return back to an earlier question that Aaron asked prior. When you were speaking of virtual visits, you and I'm going to pull up the slide, you talked about the fact that you did them in multiple modalities. Do you have any sense as to, of those modalities, what the sort of proportion was? What was more, what was less during the COVID period?
Oh yeah, we have data like you wouldn't believe. But actually, even though you can't see that picture very well, that is the accurate picture of all of our volumes by week through COVID and by modality. So the gray is in person, the pink was telephone, and you see early on we had this crisis mode. People weren't ready to schedule video visits, so they were using telephone more heavily, and then it gradually moved more towards video, which is the darker sort of purple. What we have found, though, is especially with the some of the populations that we serve, like access to bandwidth, access to a smartphone that actually can handle our video visits is a barrier. And so we've kept telephone as an option for care, mainly out of a need to meet all populations with virtual sort of access. It's one where we attempted in the early days to try to really encourage people to use video over everything else because of the belief that the quality of the interaction is better. And we still believe that the quality of the interaction is better when you can see somebody, but we didn't want to completely eliminate telephone. So that's that's the breakdown. Right now we're probably I'd say somewhere around a fifth of all of our virtual visits are telephone, and then the other 4/5 are video.
Right. That's great, Mike. And Aaron, I know you're out there. Aaron, take a look. The American Journal of Managed Care in January 2021 had a very interesting study that has some great details both on telephone versus other. They found it was about an equal mix in an early period of the COVID activity. The fun thing about it is they also look a little bit as to say who was using telephone and who was using video. What did they do in the case of low bandwidth kinds of activities? So it's a relatively new study that's out there that I think answers some of those questions. Let me Mike, come back to you and ask the question about what were some of the sort of measurable successes? I always find if I'm going to go talk to the rest of my organization, the more I can talk about something tangible and measurable, the more persuasive I can be. Can you give us a sense as to where Froedtert has seen measurable successes and tangible benefits?
Yeah, I mean, I think you kind of saw it a little bit earlier, but we pretty rapidly got back to basically at parity with what our pre-pandemic volumes were when you kind of look at our graphs. And so, the fact that we rebounded to 100% of our pre-pandemic volumes is, I think, a pretty good outcome. I mean, it's one of the probably ultimate outcomes. If you look at some of the other things that are a little, I'd say more process driven, we were able to serve just an immense number of people without having to add FTEs. And that's especially when you think about COVID, what it would have normally taken to try to monitor 10,800 people in their homes, we were able to do with essentially 1.5 nurses per shift, and getting 37,000 COVID tests ordered and get people scheduled and those kinds of things. That would have taken a pretty significant call center to do, but we were able to do it with one provider, managing this through an asynchronous process. So I think when you look at some of the volumes, when you back into how we actually achieved it from a workforce perspective, those are some outcomes. So the value delivered per dollar that we put into it were pretty substantial. The clinical quality metrics we're still sifting through, right? So one question would be, if we're doing all this remote monitoring and engaging people with their mental health or with their diabetes remotely, did we see any drop off in our overall quality sort of scores or A1C measurements and those things? We don't have all the data in yet, but our belief is that we actually didn't miss much of a beat when it came to the actual quality metrics, even though we shifted a whole bunch of care to the home. So those are when we think of outcomes, those are kind of the buckets we would look at, sort of growth, cost of care, and then clinical outcomes, and those all seem to do well. And then the last was our patient satisfaction data. We measured incessantly, during this period to see what people were, what was their feeling about virtual care? How are they, where were they finding things, either helpful or not helpful? And we iterated quite a bit during that period. But our virtual, like the patient satisfaction scores we had with virtual were on par or better than what we had with our in-person care. And we're already, kind of top decile performer in patient satisfaction. So those were good sort of outcomes metrics over that period of time.
And Eric asked that question. So at any point in the COVID, did you see a dip in those scores, or were they fairly consistent and equal to what inpatient was throughout?
Yeah, the one time we saw a dip wasn't in the overall satisfaction, but in the sub metrics around like how easy was it. When we really forced everyone, including the laggards and the people who never wanted to do this, into that mode, I think that there were people that struggled with some of the technology, and then they would give us that feedback, but they actually never suggested that their overall satisfaction was lower. And I think they were thankful that we were still, able to offer something, even though it was technically challenging for them. But then as things have migrated back to like more of you get to choose your, path. If you want to do it virtual, you can. If you want to come in person, I think that sorted out that population that would, much rather just come in person.
Yeah. So desperation breeds a little bit of tolerance when it's all said.
It does.
That's great.
It absolutely does. Yeah.
That's great. So, Darrell, I know that we've talked to some who had other issues. Do you want to highlight any of the other issues that we've seen in other health systems that they're now trying to get their hands on that made it difficult for either to measure success or get a handle on the success they were having?
Yeah, sure. So I think one of the challenges, at least, and Mike alluded to it, is really around the value piece, right? In terms of, value is probably one of the most nebulous of the measures. So it's been really the most challenging in terms of sizing the impact of virtual care on that. And part of the challenge is that we've not really had a long time period to truly connect virtual visits to end outcomes. But equally, the mechanisms to measure virtual care outcomes remain, for the most part, pretty immature. For example, how do you know if the virtual visit appropriately replaced or delayed the need for in-person care for that presenting issue, or did it add an inappropriate visit without adding value? And we're seeing some systems try to address that insight through delayed patient surveys after the visit to get a proxy for the issue resolution or outcome in that sense. And we're also seeing post-hoc analysis of more longitudinal care journeys to understand the impact on appropriate utilization in systems, and also where there's cost accounting existing, you might also look at the economic impact too. But again, I think it's been pretty early days for most in terms of navigating that.
Right. So I know that one of the places, in several places that we talked about, because there was such a rush to meet the demand, they found that they really didn't have appropriate tracking information. So there was a very interesting article that came out in Health Affairs that looked at claims and made some very great insights in terms of what took place. One of their sort of basic theories was, well, it doesn't look like there was as much activity as what we thought there would be. And what we found is that so many of our clients and companies we worked with struggled to really capture what was taking place because it was happening so much And so they had a hard time then transitioning those to then making sure that there were appropriate claims filed and everything else like that. Mike, I'm assuming that on the backside of the organization, you did not have those same struggles or were able to resolve those struggles fairly quickly.
Yeah, we were. I mean, it was dynamic, right? Like we were getting different guidance, on a pretty regular basis about what, payers would pay or not pay and how to code things. But the team was, quite flexible, and we did hold back a lot of, claims until we got a lot more clear guidance about how these payers wanted to manage them. So I don't live in that world, so I don't know exactly all the, consternation they went through, but I do know that it was a dynamic time, and the group definitely had to flex a few times more so than usual.
Yeah, that's great. Okay, so we have about 8 or 9 minutes left. I promised Susan and John and a couple other people will get to their reimbursement question, and so we're going to save it for last. So before we do that, Mike, I'm interested in, and again, one of the things that Froedtert's known for is innovation. I'm interested in what you think the role of innovation has been in virtual care at Froedtert, and then Darrell, I'd be curious what you're seeing others doing similarly. Mike?
Yeah, it's a good question. I think, on one hand, an academic medical center sure should be doing some innovation just because it's kind of in the DNA. But I think it's really targeting virtual care. I'd say it was that investment in Inception Health and basically that investment laying the groundwork for this, pre-pandemic, and then that providing this toolkit, that we basically could go to of different modalities and options in that, very, challenging time where we had to, ramp things up very, very quickly. And I think then the only thing I'd say is just if you've got an innovation mindset, you've probably gone through some forms of rapid iteration instead of, that sort of overall mind, kind of mindset, and you're used to things not being perfect out of the gate and iterating. I frankly think that what the pandemic did for most health systems is it forced them to be innovative. Forced them to kind of go into that rapid cycle iteration mode where they typically have not been comfortable doing that. I think we had a little bit more of that baked in because of who we are, and then the investment in digital and Inception Health, like going back 5 years before the pandemic.
Super. Darrell, any other thoughts around innovation and where we're seeing it?
Yeah, absolutely. So I think we've seen quite extensive innovation in the virtual care space, but I'll just touch on maybe innovation around a couple of things. And one's around the Peri virtual visit interaction, and the other probably the virtual visit interaction itself. So let's talk about the Peri virtual visit interaction. So that's everything that's happening around the virtual visit. Now, it's common recognition that the video visit by itself is somewhat limited, but linked to adoption, there's a momentum to really do more with the virtual visit through bringing more modalities around and into the visit itself. So this might be through bringing more data into the virtual health visit from the patient end, such as vitals, imaging, point of care testing, direct observation of the, home environment as it relates to SDOH, and even, third-party physical examinations, wearables, et cetera, another avenue there. But the other broad theme for the Peri virtual visit interaction is integrating touch points after the visit so that actions can be triggered to further facilitate care management. For example, connecting the virtual encounter to at-home blood draw services or medication home delivery services, or even connecting the patient to that next point of care through integrated ride-sharing apps. And then, as promised, the second thing I want to talk around is the virtual visit itself, which we're seeing this movement from that historically linear, provider-centric and rigid form, which was mainly applied to simple and episodic use cases such as urgent care, to something which is more multinodal, where there is a dedicated patient virtual room that others can come in and out of, for example, APPs as well as physicians. And while that patient waits, they can access digital content, for example, educational materials centered around their reason for visit, perhaps, or meditation guides, or even interact with chatbots to handle administrative issues, etc. So really, that shift has allowed a multidisciplinary team approach and application to more complex and longitudinal care cases, which means that virtual care can progress from providing convenience at a distance to managing complexity at a distance. And that, of course, opens up to far more use cases. So feel free to add to that, Greg.
No, I think that's great. And again, I do want to sort of tackle the reimbursement question. So Susan and John and others have asked. So my first thoughts around where do we think payers are going to go in terms of payment for virtual? Where do we think CMS is going to go? Any thoughts you have on reimbursement?
Yeah, I want to be really careful not to, I am not an expert in this space, but I think our view right now is it depends on why you're using virtual. So if you're using virtual as part of primary care and you're using it in a way where maybe the visit isn't the center of your strategy, you're hopefully in a risk-based contract at that point, or you got to be figuring out how you're going to take on risk, because these broader use cases are remote monitoring and digital therapeutics really only work if you have some form of risk. Not only, but the vast majority. And then for the rest, I think we're of the mindset that this should be at parity. We're basically operating as if it will be, at parity with in-person. We know that not all consumers feel that it's the same, and they think it should be priced less, and we know payers think it should be, paid at a lower rate. We're not necessarily aligned there, but we're going to just kind of take it as it comes. But in the end, we're not going to change a decision about whether a visit should be in person or virtual based on how much we get paid for it. So it's something we're going to try to manage, just within our own cost structure.
Right. And again, I think we agree very much with what you're saying, Mike. Again, I'm anxious for more people to work their way to a more value-based risk kind of thing. In those places in which it's fee for service, I think we see a couple things. I am not surprised that there is now a move to bring back some of the things like prior relationship kinds of things for reimbursement. And I know that there are organizations in the U.S. that are upset that that's happened. But I think if you think about it from a common sense standpoint, there's a rationale behind that. I do think as we expand the types of visits that we do, deal with more complex sort of visits, that then you see where there's opportunity to demonstrate even greater value and maybe get to different rate structures based around that. But Darrell, any other thoughts around reimbursement?
Yeah, I think the only other thing I would add is that the payers clearly are seeing the value of virtual or telemedicine more broadly. As you've seen, the spate of acquisitions and partnerships which have happened, right? There's been Cigna acquiring MD Live, and then there are close ties between CVS, Aetna, and Teladoc, and others. So essentially, once you've got that value proposition on the payer side, you're likely to see incentives which encourage virtual health on the other side, and that clearly requires, I think, something which isn't dramatically below parity.
And I do want to, and Mike, I appreciated your examples and use cases. I loved in particular the one around remote patient monitoring and care coordination and that kind of stuff. Because again, those have been opportunities for people to look to offer the service in which there are opportunities to get reimbursed. And so again, the fact that you have been successful at that and it appears as if there's a clear need for that, I think creates an opportunity for people to find services in which maybe the reimbursement is there. Monique, I need to hand this back to you.
Thank you so much, Greg, and certainly the speakers, Mike and Darrell, for sharing so many valuable insights on the topic of virtual care, which, as we've seen, is certainly increased in value and adoption throughout the past year and a half. So that concludes the time we have available for today's session. Shortly, all attendees will receive an email with a link to the webinar session replay and the presentation. We certainly welcome your sharing that with others in your organization. On behalf of the American Hospital Association, thank you so much to our attendees for making the time to listen in to today's webinar, and certainly a very sincere thank you to our sponsor, Accenture, and to our very informative speakers. That concludes today's program. Have a wonderful afternoon, and please stay safe. Thank you.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.